interesting.
Thank you. Thank you very much. Okay, now we have already heard what is the burden of heart failure. So we can see 60 million people in the world. I think that this is underestimated. If we think that the heart failure is present in population of 2 to 3% in Europe, even more. We know that many patients with heart failure and preserved ejection fraction are not recognized. We can also see that this is the #1 reason for hospitalization for the people older than 65. That 30% of patients will come back in 90 days after heart failure hospitalization, and that if you are hospitalized because of heart failure, you are already 1/3 dead, let's say. You will die in first year, 30% of patients will die. So we don't have to talk about the quality of life of these patients, about the depression and everything else. We have already mentioned that heart failure hospitalization is a marker of heart failure mortality, all-cause cardiovascular mortality, and also all-cause mortality. It's not just a marker, but also it is actually a cause of mortality, as you can see. You can see the highest mortality is after discharge. You can just imagine what are the reasons for this. Of course, it is a biology, and it is the process of the disease, but also maybe there's also some our mistakes during the hospitalization. And you can see here, if you have 4 hospitalizations in your patient, the chance that he will survive at the end of the year is low. Why is that? You can see here, your patient is emergency room, the focus is here, many doctors here, now he's in intensive care unit, but now he's in our department. And you see, the focus of our care is going down. Here are my fellows that are writing discharge letter. I'm in the cath lab. So you see, the focus is very, very low of our patients, and then in ambulance, I'm again watching my patient. So that's why we have a gap here, and that's why maybe there is a vulnerable period of our patients immediately after the discharge. And we need a drug that is efficient, without side effect, that will help immediately after the discharge. So we will answer some basic questions. Why we should prescribe empagliflozin, when, and how to prescribe. Okay, why? Because we have big randomized control trials for heart failure with reduced ejection fraction and also for preserved ejection fraction. Please look at these numbers. So we have absolute reduction for 5% or for 3%, relative reduction 25-21%. I look at this number for number needed to treat, 19 for reduced and 31 for preserved. Well, what does it mean, 19? So this is 19% reduction for cardiovascular death and for heart failure hospitalization. You have seen what does it mean. Not for I don't know, itching, for so very tough endpoints, let's say. And also, what is the price? Number needed to harm, more than 100 for genital infection. So, can you see what does it mean, number needed to treat? For the drug, that is in Croatia, I don't know, 100 kunas or even less. So this is lying under these results. But we still do not see one important thing here in these results. You will see later. So we have the drug for all ejection fractions, which is good. Just think about the ARNI. So how many times when I look my patients, he had ejection fraction 38%, 40. Oh no, I will write 35 because my insurance will give the drug now. So in this kind of drug, I do not have the problem. I know that he will be effective for any ejection fraction. We know that ARNI is also effective, but not so effective and we have some limit and with preserved ejection fraction below the 50-some%. So, and here are safety outcomes. No difference in hypertension, volume depletion. We have some difference in genital infection, but no urinary tract infection, so no side effects, and no ketoacidosis, what is important. So, because we didn't have the patients with type 1 diabetes mellitus in both trials. Now it's the question when to prescribe. And here's the secret of these trials. It's not the secret, actually, that you can see that the drug is functioning from early beginning. In the EMPEROR-reduced trial, you can see also here. So in first 13 days, it starts to work. And also in preserved trial, you can see also very, very early beginning. So not 13, in 12 days. And in EMPEROR preserved, it starts to work in 18 days. So we like this drug because can you imagine if you are giving the drug and you know that this drug will produce the result after 2 years? So it is a question. So we like to see the results immediately, especially in these vulnerable patients after the hospitalization. Why is this? Is empagliflozin diuretic? The company hates when we say so. My ex-boss, he used to say about the classic diuretics that you are permitted in times of great danger to walk with the devil until you have crossed the bridge. So they think that diuretics are devil because of all side effects, cardiorenal syndrome, hypokalemia that are producing. So we are using them because we need. But if the patient does need diuretic, we will not give them. But what is with empagliflozin? So if it is some kind of diuretic, it is good diuretic because he will take like interstitial fluid and he will not change the intravascular volume. He will not produce renal insufficiency. But what with these results? We can see that the empagliflozin is acting in a good way in the patients with volume overload and without volume overload. We cannot say this for classic diuretics that we are using. So probably this is because of many, more than 80 mechanisms of empagliflozin that are not connected to the basic function of the SGLT inhibitors. But what is the problem with EMPEROR-reduced, EMPEROR-preserved trials? Because they use chronic patients, stabilized patients. But we need data for new onset heart failure and for acute heart failure patients, and that's why we needed EMPULSE study. You can see something similar that we have got with Pioneer study and with ARNI. So in this EMPULSE study was very positive. It showed 36% reduction, actually the clinical benefit in compared to placebo. What was this clinical benefit? This was mortality, this was heart failure events, hospitalization, and also improvement in the quality of life. So this was no matter if this heart failure was de novo or decompensated chronic heart failure, and also no matter with ejection fraction for reduced and also for preserved ejection fraction. So you can see the empagliflozin was better compared to placebo. And so this was the conclusion of EMPULSE study. So 36% more likely to experience clinical benefit with all ejection fractions, de novo patients and chronic patients, and there was no safety issues in this trial. So we have consistent results as for EMPEROR-reduced and also for EMPEROR-preserved. So this is bringing us now to the point how to prescribe these drugs. So we know that the main point why we cannot prescribe some drugs because of renal insufficiency, because of hyperkalemia, and also because of hypotension. But if we look empagliflozin, it does not have this kind of problem. So it has shown it didn't show any difference in hypotension, in symptomatic hypotension. So even hyperkalemia was less pronounced. So you can combine it with every of these drugs, especially, for example, when you look for eplerenone, for mineral receptor antagonists. You can see that with empagliflozin, you actually have reduced hyperkalemia, so there is increasing chance for you that you will be in opportunity to keep mineral corticoid antagonists, and that you may increase the dose of them. So for every profile of your patients, for heart rate, no matter blood pressure, kidney function, you can give actually the drug without any problems. You don't have to think about these parameters. So I think that SGLT2 inhibitors should be one of the first drugs that should be given to a patient together with beta blockers, and then you can think about the other drugs, ARNI, MRA, depends on the blood pressure and everything else. So, are there some safety issues for those who believe about urinary tract infection? There is a huge retrospective study. So, more than 100,000 patients, and we didn't see any difference in urinary tract infection. So, the only problem was actually the genital infection. So, what is the problem with HFpEF in Croatia? Of course, we still do not have in guidelines the indication for empagliflozin. Of course, we will not have insurance, but as I already told, almost 50% of our diabetic patients are patients with HFpEF are diabetic patients, and these patients that have HFpEF and diabetic usually have the lower NIHA class. They have renal insufficiency, volume overload, so one more reason to give them empagliflozin. You can see here the meta-analysis, also with dapagliflozin, that the results are very, very similar, and so there is no class effect. We can count on these drugs. So it's not just accident that these drugs are shown that they are so good. And we are waiting with very, let's say, we are very excited to see the results of impact in my study for the patients after myocardial infarction. So my point would be, there is no reason to waste your time. So put empagliflozin the therapy, and as soon as possible. There is my friend, cardiologist, she's not here. She told in Barcelona when we were talking about empagliflozin, because today will be yesterday, tomorrow. So this was, she was thinking about empagliflozin in the island of Murter, and also she was thinking about the life and what she will wear that night. So that's what happened. Okay, thank you.